Well, excellent. Thank you all. We really appreciate your contribution and um, getting much more detail on the programs that all of your agencies are carrying out in global health. Why don't I open this? We have another 30 minutes, and so I'd like to open the floor to the committee and also to the general audience. We'll break at 3:15, and then the second panel will come on at 3:30. Yes, please.
Since sorry.
Go ahead.
Since you finished with that slide, I have to say something. So I'm extremely excited to see that. And we were mentioning earlier this morning before you guys were here about the importance of this report and how even today in the United States, there is not a national trauma care system. If you get injured in West Virginia, something very different will happen if you get injured in Ohio or in Pennsylvania. And that is because there is no enough planning and nationwide systems and how to take care of injured people. So when you think about internal and external, developing health systems, including the creation of something like these, here and there, will have an impact everywhere.
Oh, yeah, we can do that after Valentine's.
Yeah, I just like to, what happened with the investment 2009 document? There were $2 billion that were going to be invested up to 2012 on non-communicable diseases. And I'm asking you the question because you're really external on everything that you are doing and so forth. Do you have any idea?
Sorry, which two billion were you talking
It was
about?
$2 billion was the suggestion to the government. This is in the document that came from here in 2009 to be absolutely devoted to non-communicable diseases.
You know, we had a flatline budget at NIH.
Put your mic on, please.
On there. It's on there?
It's on. It's good.
We had a flatline budget at NIH until a year ago. This past year was the first year where we had a $2 billion increase. About 40% of that was earmarked. So we had no increase in budget in NIH for that following that report. But I'd have to go back and investigate exactly.
The only reason why I'm asking is because many of you mentioned non-communicable diseases, which is basically is more than 50% of the people who die today across the world is related to what was pointed out. And frankly, I think there is a great concern because the expenditure is going to increase progressively as people age. And I just want to emphasize that aspect.
Yeah, and I'd also say that we started a program to train our U.S. fellows overseas in the NCDs. We put out an all points bulletin about 7 years ago and got no takers. And then I went to the global health groups like Mike Merson and Seattle, Washington, and they had people who were lining up to do NCD research as fellows. And so that program has started. It's small, but the people have been outstanding. That's the kind of program, and growing those young people and building those academic departments in the U.S. that can lead to a major change in our ability to work in the global health space in the 21st century. So I think there are many people at university and academic centers who believe in the global health agenda and want to work in that. The opportunities right now are not there for their research, and we're trying to build those.
We have two charges. One is more on priorities, which you've addressed, although I think we'd have to write a textbook to cover everything that all of you mentioned. We can come back to that if we have time, but another textbook, yeah. But the second part of our charge, which we were given, like the previous group, the previous report, was to deal with the architecture of global health in the U.S. government. And this is what Jen Dye mentioned early in her introduction. And we as a committee obviously are aware of what happened with the Global Health Initiative, to just take one effort that came out of the report. And we are trying to decide as a committee what is worth our trying to do with, what should this committee do? It's in our charge. We watched others try to deal with it. What would you advise us? Are there ways to make the U.S. government more efficient, have better coordination, avoid duplication? Many of you mentioned cooperation, but we all know what happens and how much you're dictated by your budgets. As in fact, some of you have mentioned that already, Ariel, and particularly you did. So please, we'd like some guidance, all of us, because this is a short report, what's called a fast track report. And so we need to know how much effort and energy we put into priority setting and how much we put into architecture setting, if you like. And so that we'd like you to be frank with us and advise us what you think would make you all work more efficiently. Is that a fair summary?
Yeah. If I can add to that, we have a full plate, and the question that Mike is asking is that apparently there have been several attempts to improve coordination in the past that have not succeeded. So is it worth our time to try it again and make recommendations that would never be used?
Right. That says it very bluntly.
Let me start. Let me start. And I think that it's a very important question. I'm glad you're tackling it. Obviously, many of you know this, you have lived through this in different ways and perspectives. But maybe before I go into that space, zoom out a bit. Because of the success of international development, and the point I want to make is the overlap of development and global health, and how there's been some confusion of roles. Because of the accidents of history, I would say that particularly with HIV/AIDS and PEPFAR came in what was already a smooth transition into the success of development. As I mentioned, half the countries that were low income in 2000 are now middle income. USAID's success is development success, that when countries are healthy and economically sound, governance is good, education, and that's great. And it's happening around the world, and it's been an incredible period of success. When President Kennedy established USAID, he said very clearly, our goal is to provide this assistance until countries can stand up on their own and walk with dignity with their own resources. And that's what we have been missing. It has been happening tremendously. In the last 15 years or so, USAID has graduated over 20 health programs. That is, Mexico doesn't need direct financial assistance for the health programs. Brazil, more recently Peru, and so many other countries. China, India, we're just dangling by a little nail there in terms of the resources we're contributing. Meaning, for USAID, success is development success, and eventually we guide programs, and eventually we transition from full offices to from full missions to an office to development assistance, and then we plan for this. We are planning this continuously. So in a way, the world of global health is much larger than the world of development assistance for health. But because that's where the money is, it's not surprising that a lot of the agencies have been busy in that space. And I know when it comes to Roger, for example, has this broader space in all of the other agencies too. It's only AID that has a more limited space, let me say, but it's the space in which, because of the PEPFAR resources, that has been more contagious. There's been little attention paid to the rest of the world. We are working in 70 countries, concentrated our efforts in about 30 or 35 countries. There are 150 other countries. How are we looking at the other 150 countries? I believe HHS has a lot of important functions to play across the various dimensions that we heard here today. And yet there's no budget to have health attachés in all of those other countries that we have now graduated them from, because the global health development assistance money is not for China. I mean, we do a few things out of self-interest and MDR-TV and the like, but it's how do we think of global health beyond the development space and beyond the emergency program that PEPFAR has been? And that, Michael, first zooming out to see that the global health space is much bigger. I think the global health security, the R&D efforts, FDA, make clear that the world of global health is much bigger, but the resources are not there for those other spaces beyond where PEPFAR and USAID are big. And I think that, so that's a much bigger architectural issue and budget issue, because I believe HHS should have resources to do many of the cooperation, not assistance, but cooperation across all of the spectrum that you heard just now, but there's no budget for that. And I think that that's important. And so, and we struggle, right? Each of them struggle. I mean, I'm focused in the countries I'm focused anyway, but I'm sure that some of them would like to do more of what they do with PEPFAR money somewhere else, but there's no money to do that. So I think that that's probably the most important thing, Michael, and to the extent you actually make that pool bigger, then the smaller, when people are now trying to fight for those resources, will look less of a challenge. But the second thing I will say is that, especially with PEPFAR being established outside of USAID for an emergency, good reasons, important program, has turned around Africa, and we all went for that, as you know, Michael. And, but the emergency is subsided. And it's hard to say this. It's hard to say this. I mean, because the problem is not gone, remains very challenging. But the ministers of finance of Africa will not sense it the way they saw it in 2000. We all saw it in 2000. That change needs to call for changes in how we go about doing what we do in a particular area. And in the provisional sense that perhaps you were asking your question, Michael, is that I think clarity on budgets at the global level will be very helpful, as opposed to leaving the countries try to fight off for their budgets in niche missions with the CDC and the AID folks trying to figure it out. I mean, clarity on budgets at the global level by countries, by priorities, and then leveraging the comparative advantages of each of the agencies. As I said, we had an emergency and the response called for all boots on the ground, CDC, everybody to do things. But eventually, we had other, and I'm coming here because as someone who will be turning into a pumpkin in 3 months, so I will no longer be in this position, but I've been, of course, involved in global health for a long time. Simply to say that that world had changed, and we needed to have CDC involved and NIH involved. Everybody has to be involved, and it was a big challenge. But at the same time, the question is, when you start using the same implementing partners that USAID is created to do development, and it's just routing money around and then competing who has more budget. I'm being frank, because you asked me to be, Michael. And I'm saying to you, well, maybe we are getting to a space where there's no longer what the emergency called for, that there are comparative advantages, and that there's a much larger space of global health that needs to be addressed, that needs to be also resourced accordingly beyond the space of development assistance for health.
This is Dr. Berkeley. Can you hear me? Pardon? You can?
Go ahead. Yes, go ahead.
Yeah. Along with that larger space, I'm concerned that we are doing in the United States what we're asking other countries to do. One situation I would just want to get clarified, asking our CDC speaker. I think we remember during SARS that the working relationship with the state public health departments was seriously lacking in communication and coordination. And although infectious disease epidemiologists were sent to many of the states, they did not stay for various reasons. And a study done soon after showed that the situation was just as bad for any pending epidemic that might occur. So I'd like to just know how you would describe the current working relationship with the states, and whether this is optimal for future outbreaks, and maybe the same question for other agencies if you have that mandate. Also, you know, among the developed countries right now, the one place that has the highest maternal mortality rate is Texas. You know, we're becoming more and more global, and I'm really concerned that we're just still them and us kind of stuff, and that this is not emphasized as much as it should. So I think you understand my question.
Yeah, thank you. This is Vic Kapil. So I'm here representing the Center for Global Health at CDC. So but there are some analogies, as you noted, and I think the question that you asked about states here in the United States is certainly relevant for our global activities as well. You know, we've worked very hard in that area to build our relationships with our global partners around the world. Our focus really, as I mentioned earlier, we have tried to focus on building sustainable capacity, and I think that goes for states as well. Now, obviously, there are, as Ariel and a number of others have mentioned, you know, obviously there are always challenges with budgets and you know, and focus areas change over time. But we do think that building sustainable capacity for global health activities in the countries where we work, in the places that have the highest burdens, that have the greatest challenges for both infectious diseases and NCDs, and I'll come back to NCDs in a moment because NCDs are a special issue from my perspective. Building the capacity for public health activities, meaning prevention, surveillance, epidemiology, the lab capacity, building the workforce, including our field epidemiology training programs, which again exist not only in other countries now, to help them build that type of field capacity, but also the EIS programs here in the United States, building their capacity for response, preparedness, emergency operations centers, and also very importantly, I'm not sure anybody really clearly touched on this, is the enabling systems. All the things that need to be in place, and this may be also what you're touching on with states, the organizational structure, the evaluation, the monitoring, the health and risk communications, the ability to organize and convene partners. You know, all of those things are part and parcel of an effective public health, functioning public health system. And as people have mentioned, I think Roger did an excellent job pointing out in West Africa the challenges that existed pre-Ebola and what that meant for West Africa when we had the Ebola outbreak that began in West Africa, and how things were really very different in places like Nigeria, where there was at least some infrastructure, some public health infrastructure in place, and how the experience was so different in those countries. I'll close by just mentioning on non-communicable disease. I do think there are special challenges with non-communicable disease. We have, albeit time-limited, global health security funding, and we've done a lot during that time, and we have probably through fiscal 19 at this point. There's much more work to be done. The non-communicable disease activities, you know, are even more of a challenge, and we have a challenge, and I'm sure others have already mentioned this, and I know that others have a challenge on global non-communicable disease work is very challenging because it's much easier, I think, to make a case for infectious disease threats and threats to the homeland as opposed to chronic diseases overseas. Now, I will point out, I'll close, I will point out this great slide from David about the development of national trauma care systems. I will remind you, just a friendly addendum to this, that the biggest killer of Americans abroad is also road traffic crashes and injuries. So these are things that I think we need to bring home to people. Americans traveling abroad, that's the biggest killer for Americans.
From now on, NCDI. Let me put the I at the end. Talk about NCDI. Don't separate. NCDI.
Okay. All right, it's my turn. I have actually two questions. The first one that had to do with NCD, but I like the NCDI because it applies to infectious disease. But specifically on NCD, I disagree with the comment, or at least I want to put it on the table, that maybe it's easier to link infectious disease to national security. But in fact, my question is, how do you feel from DoD's perspective, the threat to national security when you're looking at NCD taking up over 86% of the, healthcare costs, which is approaching 20% GDP. That itself, the 20% GDP is a risk to national security. And 86% of that is from NCD. And the fact that I believe 8 out of 10 age-eligible men do not qualify for military. I don't know what that right term is, but to join the military from a health perspective. And the challenge of having individuals on the battlefield that have chronic diseases. So how do you view that from a DoD perspective?
We agree with that clearly NCDs, particularly looking at the population that we recruit from, is clearly a problem.
And so I think it would be important for us to, make the case that change that perception that NCD is less of national security than infectious disease.
And just to follow up on that, I certainly wasn't making that point.
I understand you, but you're raising a point that I think we
that's
should
exactly
address in
right.
the
I was just trying to raise the issue that I
Right.
think the perception is out there that somehow it's less important of an issue.
But as a personal view, I would argue we haven't been very successful in our own country
Yes, I agree.
on the NCDs. So figuring out how to export that and attack it across the world is another part of the challenge here if we aren't as successful as we need to be in our own country.
That's why I like the idea of NCDI.
Well, and just to add on to that, one other thing, just on the national security side, like the microbiome, how does that impact some of these areas? Is there something that nefarious
Maybe
could be
that's where
done
Roger's trying to
to
get it.
the microbiome that would actually trigger what we're considering an NCD?
Right.
Some of those distinctions may fall away with time because
Correct.
I think they're
Right.
blurred.
My second question actually had to do with training and research, but I'm going to let you answer first.
I was going to say, on the NCD, one of the problems I have or I see is that we have a lot of these infections that kill acutely. But when I go to a university campus, I can find that 90% of kids are immunized against flu, but maybe only half are immunized against HPV. That's a disease that's going to kill them. It's going to kill them at 20 or 30 years when they're off campus and no one cares. Right. It's not a priority. And if I look at the NCD agenda and disability adjusted life years, they're just life years, things like obesity, smoking, untreated hypertension, alcohol, these things are issues which are going to shorten the life of Americans by years. And I think those really have to become a priority. How can we learn from that, from the global health agenda? I mean, we've worked in Mexico, for instance, on the sugar tax. Mexico, South Africa, people are putting in sugar taxes, salt taxes. We're learning from Australia about these terrible covers on cigarette cartons that I go to Dubai Airport, I can buy cigarettes that are beautifully colored from China, or cigarettes right next to them that are ugly colored from and illustrated from Australia. You can't buy the Australian cigarettes and give them to somebody. So we're learning from global health about the NCD agenda, and those are important lessons. And I think I'm looking at Valentine, we were just in El Dorado looking at cardiomyopathies in pregnant women. Where are we going to learn about that except from that population? And who will it help? It'll help deliveries in the United States of people from those backgrounds. We think about the triple negative African American women who don't respond to chemotherapy, cancer therapy. We've learned about that from African investigators in the U.S. who were defining this. So we have a lot to learn about the NCD agenda from these global health investments. And I think that's where the future of discovery will be. And that's why we need to train people to address these problems, identify the difference in distributions and determinants of disease, and understand how to deal with them at home. Julio Frank says that local and global are part of the same spectrum, and I think that's what we're learning. I would also say to Ariel, Ariel has an issue because USAID works with development assistance. NIH is not a development assistance agency. We are a research agency. We're looking for the best science, the solutions, the interventions that work wherever they are. And then the application of them is, it could be development assistance. But I think it's that research agenda which keeps us separate from the State Department and from those issues. I think that's an important distinction.
So I agree with that. And before I get to training, because I agree with you, there's clearly a need not just to train NCD researcher, but really train the next generation. And that is linked to the second point I wanted to make. I hear about in your discussion, actually maybe even in the earlier one, the importance of technology innovation and big data, and how's that going to change biosurveillance or decision makings, and obviously very relevant from a global perspective, but truly relevant in a local setting as well. So again, it's the same spectrum. So I hear about that, and I hear about the question on architecture, or at least the task that we were charged with. And you were alluding to, Michael, on architecture in terms of interagency cooperation and coordinations. But I think there's another piece of architecture that actually is very important, and I always look at that as a catalyst to change the challenge of human beings, which is what you're alluding to, which is technology infrastructure. And that, I think it would be a mistake for us to look at a big data architecture / technology infrastructure that only cover NCD, that only cover coordination, because it is the same infrastructure. If you want to deal with a trauma system, trauma care system, you are looking for the same data as, or it will be the same infrastructure collecting the same data that you will care about from infectious disease and potential outbreak, or, you know. And I think it would be, to me, it's going to be really valuable for us to think about a common infrastructure that simply allow us to get the data and make that data be usable for all the questions and needs of the different agency, rather than thinking that there's a need, and to address it, the infrastructure bill comes afterward and it becomes a vertical silo, and then you are non-interoperative if we start from the need first. I think there's a need to really think about infrastructure, and I wouldn't think of it as a national structure. I would think of it as global structure. So I want to, and the training now needs to be the whole new generation who knows how that structure works and how to make use the data and the tools that leverage it.
Thanks, both Vikas and I were thinking on, we all agree on the importance of data and interoperability. More than architecture is interoperability. Right now, for almost anything, really, if you don't have interoperable data, you cannot, I mean, Google didn't have to create an architecture.
When I say architecture, that includes the hardware, the network, the hardware, the software, and the data model. So I agree with you. I'm not making that as a separate statement.
And I'm simply asking you to stress interoperability. Whenever data systems evolve to have interoperability, USAID has for over 30 years, over 300 or so national health service. The demographic health service has been an incredible part of the success story of the last 30 years. And that data, which is generated with partners and with countries, they feel ownership of the data. That data is the official data for the countries, for the UN agencies, for the US government, for academia, and so on and so forth. So demographic health service has been doing a lot of that. And then the data is used by everybody. District health information systems, with IT coming up, has become more and more the expansion of that routine information systems become very important. Linkages to electronic health records will become very important. And then the absorption interest right now on vital registration, birth registration by statistics, very important. Right now, we do not count all births or all deaths, and we're always sort of guessing or trying to develop specialized surveys. And if I came back to the demographic health survey, we have developed already an NCDI module, and the module exists already, has been developed like any of the other modules, is being used in some countries, but unless there's a lot of energy behind them and a demand for them and resources for them, many countries leave it out, right? But we can now, as part of our national surveys, household surveys, which are national representative samples, we could also now have more data. In fact, it is that data that has allowed us to make the case epidemiologically, because we're already measuring the basics of whether it's obesity, exercise, smoking, and so on and so forth, that allow us to make the case that this is a very important problem.
Thank you. Jill Gay, What Works Association, Chief Technical Officer. And my question for the committee to consider is the issue of gender-based violence. I imagine that, I know CDC has worked on that, DOD must work on that. And there's a lot that we can learn from places like Uganda with the SASA project, with their work around prevention of school-based violence as well as gender-based violence. So my question is to the committee about that.
Thank you very much. Keith Martin from the Consortium of Universities for Global Health. Whether we're dealing with the NCDs or the IDs, or whether we want a competent public health system, primary care, or access to surgical care, there's something that I think we ought to consider because we're advising the U.S. government, and that is how to strengthen an effective public service. We know we not only need an effective Ministry of Health, but we need to have an effective finance, we need an effective public works, we need environment, agriculture, and justice departments if truly we're going to be able to operationalize what we're asking for here. And a great example is the National Trauma Care System. But all of what we've asked here, everybody in this room knows you've got to have an effective public service in order to implement, manage, and operationalize what we're asking for here. So I think there's a great opportunity. The U.S. can mobilize other nations, utilize its assets to be able to partner and collaborate effectively with other countries to strengthen their public service. Because everybody knows that if we track the countries that are most vulnerable, that are poorest, that have the greatest insecurity, what do they have in common? Conflict, corruption, and a lack of capacity. Look at it carefully, and nothing destroys anything faster than a political turmoil that causes devastating effects to development and to the health of a population. So I would encourage, if you would consider putting that into the document. And there are great opportunities, as we know, to partner with academia, with NGOs, and with civil society to be able to develop those collaborations. Lastly, to be able to ensure that across government, if there's a mechanism to be able to streamline and coordinate activities across state, trade, HHS, USAID obviously, defense and others, that coordinating mechanism could dramatically increase the effectiveness of what you're trying to do. And lastly, on a point of trade, the exclusion of low-income countries from trade agreements is having a devastating and will have a devastating impact on their ability to be able to generate the funds to be able to do what they need to do to pay for what we're asking for here. So that means a greater and more perhaps nuanced approach with respect to state and trade in their ability to be able to connect to the global health challenges that we're talking about here. And lastly, to not forget about, obviously, the U.S. The state situation here. Sometimes I think we sometimes mix global health with the health of immigrants. That's obviously vitally important. But if we track the global burden of disease reports, and the one coming out next week, we'll see great opportunities to collaborate with academic institutions and other partners to scale up what is already occurring in this country that can have a dramatic effect through public health, through addressing the social determinants of health, to have low cost, high impact effects on the public of this country. And if the National Academy of Sciences can find ways to be able to articulate and share the amazing work that you're doing here in a usable way for the public, because we know that the public drives the political, then we will be able to have a greater impact of what we're doing, and all the great ideas that you're offering here will have a great impact for the people of this country and the world. Thanks.
Last question and time for break. But let me first, before we do go on break, thank the panelists, our sponsors of this study. We really very much appreciate your candor. And again, as I said, we appreciate your comprehensiveness and your support for this committee and its work. we will continue to engage you. So thank you very much for coming this afternoon. If you can be back by 3:30 for the second panel.